Hello, everyone. As Sue said, my name is Michele Hart, and I've been in the pulmonary rehab department for many years, since 1999, and I really enjoy working in pulmonary rehab. And I guess, as you can guess, because I've been here for so long, and today's topic, out of breath, it could be COPD. The first thing I want to say is that not all shortness of breath is lung disease. A lot of times we have people that come to us for an evaluation here in the gym, and, they'll say, oh, I only get short of breath when I climb, 4 flights of stairs. Well, if I myself climbed 4 flights of stairs, I would be short of breath also. So, we kind of have to look at more symptoms than just the shortness of breath. And we'll get into more detail about that as we go along. So when we talk about COPD, it is chronic obstructive pulmonary disease. And chronic meaning that you have it all the time. Obstructive meaning that it's causing difficulty moving air in and out of the lungs, or both. And pulmonary refers to the lungs, and it is a disorder of the lungs. And so different diseases that fall under the COPD umbrella are listed here: emphysema, chronic bronchitis, and bronchiectasis. And we're going to talk about each one of these separately. So the first one we talk about is emphysema. So emphysema is a disorder, that happens in the air sacs of the lungs. And the air sacs are located at the bottoms of all of the airways inside your lungs. And normally they are very elastic. They move in and out with every breath that you take. And when emphysema occurs, it causes these alveoli, or air sacs, to lose their elasticity. So they don't move in and out the way they're supposed to with every breath. And the walls of the air sacs actually become broken down. And, at the air sac level is where the exchange for oxygen and carbon dioxide occurs. And so if there's damage done at this area, it causes difficulty with that transfer of oxygen into the blood and carbon dioxide out of the blood. So the airways become kind of floppy. They collapse when we exhale. And if those airways are collapsing, we get what we call air trapping. So if you can imagine these teeny tiny airways that are kind of closing down on themselves, when you exhale, there's air that's getting trapped behind that collapse. And what occurs is this hyperinflation. So the lungs just get overfilled with air. And it becomes very difficult for us to breathe the air out of the lungs. And the result is shortness of breath. So this next slide shows you a nice picture of one of the lungs. It happens to be the right lung. The reason I can tell that is because there are 3 different lobes. This is the right upper lobe, the right middle lobe, and the right lower lobe. And the picture in the background in this square box shows us what the normal alveoli look like. So you can see they're nice and round. They have a nice shape to them. They almost look like bunches of grapes, or, stalks of broccoli, something like that. And all those teeny tiny lines that you see running through those round structures is the circulation. And so this bigger picture below the box here is what the damaged alveoli, or air sac, looks like. So you can see it's not as nice and round. It's kind of, saggy, doesn't look as healthy as the picture above. And like I said, if enough damage is done, the body, the lungs, are not able to get that oxygen into the bloodstream. So the next disorder under COPD is chronic bronchitis. So this is a problem that occurs in the actual airways. So emphysema was the air sacs. This is the actual airways. And normally we have mucus that lines all the insides of our airways, and it's sticky. So anything that gets breathed in past our nose and lungs sticks to the mucus. And then we have these tiny hair-like projections that are all along the insides of the airways, and they beat up and down. I call them the housekeepers of the lungs. They're constantly sweeping up and down, moving any mucus or debris that's stuck in the mucus up, and allows us to either cough it out or sneeze it out and get rid of it. So in this case with chronic bronchitis, we have too much mucus. So it's normal to have some, but now we have too much being made. And then we get what we call bronchoconstriction, which is really just squeezing of the airways. So if we go back one slide and I show you that picture again, these bands that you see around the airway in the square box, those are smooth muscle bands that are really meant to support the airway open. And when we get squeezing of those muscles, it's closing off the airway. So we refer to that as constriction, excuse me. So those muscles are squeezing tight or constricting around those airways. And because we have so much mucus in the airways, we develop a productive cough, because that's really the only way that the body knows how to get rid of that extra mucus. So, and this cough can last for years and years. To be considered chronic, it has to last for 3 months in 2 consecutive years. So that's how we diagnose the chronic piece of the bronchitis. You know, we've all had a bronchitis in our lives at one point or another, and that's an acute bronchitis, an acute illness that we take a medicine for, it goes away and typically doesn't come back. And so the symptoms that we get when we have chronic bronchitis are shortness of breath, because we're trying to breathe through a much smaller opening in our airways. We have mucus that's plugging up the airways, so we have that productive cough. We can get wheezing, which is the sound that the air actually makes when it's passing through a much smaller opening. And then we can also have a sensation of chest tightness. And that sensation is because of those muscles that are squeezing around the airways. And then the next, and so this is a nice picture of chronic bronchitis. So this is showing you over to the right-hand side, the normal bronchial tube or bronchial airway. And you can see there's a nice wide opening. There's nothing in the way of the air moving in and out. And then the smaller airway off to the left, same thing. Nothing is limiting the air movement. And then below with bronchitis, it shows you this inflammation that's occurring inside the airway, this extra mucus that's being produced. And again, off to the left side, the lower area is blocked also. So, we're really going from breathing through the size of a garden hose to a straw. So, you can only imagine. I'm sure some of you watching have experienced this sensation. And then we talk about bronchiectasis. So bronchiectasis is very common in people with COPD. And, we haven't really associated it with COPD for that long of a period of time. It's becoming more and more, I think, diagnosed better. And so we're learning more about it and how it's affecting our lungs. And so bronchiectasis is defined as abnormal stretching and enlarging of the airways, and it's caused by mucus blockage. And so we also get damaged cilia. So those little sweepers of the lungs, like I told you about, are affected as well. we get pooling of mucus in the damaged airways. So, the airways kind of get stretched out. You might have like these little out pockets where the mucus gets stuck. And unfortunately, if that mucus hangs around, it puts you at further risk for frequent infections. And the lungs are the perfect growing place or breeding ground for bacteria and viruses. The lungs are warm, they're moist, they're dark, and bugs like to grow in that mucus that's hanging around. And so the result of all of this that's happening in the airways, we get a productive cough, shortness of breath, because all that mucus is in the way of moving air. And, fatigue is very common. And again, frequent infections are a risk factor. And so this is a picture of bronchiectasis. On the left side of the screen, we have a normal bronchial tube. And those little dots that they're showing you here are the normal cilia. And again, we have some mucus here, but it's not horrible. It's just the normal lining of mucus. And then on the opposite side of your screen, it shows you bronchiectasis. And so you can see how that airway is all stretched out. And we have all this extra mucus hanging around in there. And then we've lost kind of that lining of cilia there on the bottom of that airway. So, I think this is a great depiction of what's actually happening inside the airway. So then we're going to talk about how COPD is diagnosed. And there's a few things that we take into consideration. As I said at the beginning, we talk about symptoms, and shortness of breath is one of those symptoms. So your clinical history, your family history of pulmonary disease, any environmental or occupational exposures that you've had in the past, and then if you have an abnormal lung exam. So when I talk about abnormal lung exam, different testing that we do comes back with some abnormal findings. If we listen to your lungs, there's different sounds that we hear when there's different disease processes happening inside the lungs. So all of this we take into consideration, and we'll talk about each one of these as we go forward. So clinical history, like I said, really focuses on symptoms. And shortness of breath is very common with lung disease. And most people will report shortness of breath when they're exerting themselves. So unless people are really struggling or have an acute illness on top of their lung disease, they typically are not short of breath at rest. Coughing is common, as we talked about, wheezing, chest tightness, increased mucus production, frequent lung infections, lack of energy. And then some people also tend to lose weight in the later stages of lung disease. So when we talk about emphysema, there's a few different stages. There's mild, moderate, severe, and very severe. So in your severe and very severe stages of emphysema, people are really burning calories just breathing, and this is where that unintended weight loss will come in. The other thing that can happen if we're having frequent lung infections, we have to be on antibiotics, we have to be on prednisone, and those medications have lots of side effects also. Prednisone can cause mood changes and sleep problems and skin issues and weight gain and all kinds of wonderful side effects. It's a great drug because it helps us to breathe better, but it does have a lot of unfortunate side effects. And then if we're on antibiotics frequently, that can put us at risk for losing the normal flora in our gut, which leads to stomach issues like diarrhea or nausea and vomiting, that kind of thing. Then we talk about family history. So one of the genetic forms, or the genetic form of emphysema, I should say, is alpha-1 antitrypsin deficiency. And this occurs in about 1% of people with COPD. So what happens is that this alpha-1 antitrypsin is a protein that is made in the liver, and it's really meant to protect the lungs from any kind of damage occurring. And so this deficiency of that protein can cause lung disease, it can cause liver disease, and or both. And so we'll talk about testing for alpha-1 as we go forward, but it is basically just a blood test that people have to have. And typically, if you have alpha-1 emphysema, it occurs much earlier in life than typical emphysema or chronic bronchitis. And it comes on pretty quickly at a younger age. And, if we're finding someone who is testing positive for alpha-1 deficiency, then we highly recommend that family members be tested also. And then we talk about environmental and occupational exposure. So this is a short list, even though it looks long. There are so many things out there that can affect our lungs. Anything that's in our breathing environment, in our air, and is toxic to the lungs can cause lung damage and lung disease. So, cigarette smoking is at the top of the list. Smoking marijuana is a big issue, especially of late, because now that it's legal in Massachusetts, everyone is smoking marijuana. Vaping is a huge issue. And then we have all kinds of exposures to secondhand smoke, asbestos, radon, toxic fumes, solvents, dust, dirt, household cleaners. We spray everything in the air. We have, not to pick on any certain brands, but, the things we plug into the wall and they make the house smell nice. All of these things that we're adding to our air and we're breathing in can be harmful to our lungs. Mold is a big issue. Fireplace smoke, powders, all kinds of things can cause problems for our lungs. And then we talk about diagnostic testing. So we have lots of tests that can give us information regarding the health of our lungs. So chest X-rays can certainly show if someone has emphysema. Emphysema shows up what's the best way to describe it? So when we talked about hyperinflation before, your lungs appear much longer than they normally would because they're stretched out and filled with air. And X-rays can also be used to rule out other lung problems or heart failure. So if we do an X-ray on your lungs and we can see a pneumonia, we can see if your lung has collapsed. We can see if there's, nodules or tumors on your lungs. So X-rays is very helpful as a beginning test or an initial test to be looking for lung diseases. And then we can do a CAT scan to do further testing. So if we find something on an X-ray that we are concerned about, we can do a CAT scan. And the CAT scan really helps us to look more closely at what we're seeing on the X-ray. It's almost like slices of pictures that we take, 3D pictures that we take of different structures of the body. So, and a CAT scan can be used to look at any part of your body, really. It can be your head, it can be your chest cavity, it can be your abdominal cavity, and so forth. And then we talk about arterial blood gases, or an ABG. And this is a blood draw, but it's a blood draw from an artery. So it's not a typical blood draw from, your elbow, where we just give blood to have a multitude of tests done. This is drawn from an artery. It's usually in the wrist or in the bend of your elbow. If it's a more emergent situation, they would draw from your femoral artery, which is right in your groin area. And so when we do a blood gas, the different things that we're looking at are the pH, which is basically the level of acid or base in your blood. We're looking at the level of oxygen and carbon dioxide in your blood. And then we also look at bicarbonate level, which is a form of carbon dioxide. It's kind of the byproduct of our metabolism. So all of these numbers put together can give us lots of information about your lung disease, and if you're having an exacerbation or a flare-up of your lung disease, or if you're in respiratory failure. So it gives us lots of information. And then, like I said, just a regular blood draw or blood work in the lab can give us lots of information too. And that's the test that we do to determine if you have the alpha-1 antitrypsin deficiency. And, there is a push to have everyone that has a diagnosis of COPD to be tested for alpha-1. So I don't think it's something that your doctor would be surprised about if you brought it up to them. And then the other diagnostic test that we talk about is a pulmonary function test, or a PFT. And when we're looking at a pulmonary function test, there's lots of different volumes that are measured during the actual test. And so the first volume that we talk about here on this slide is called the forced vital capacity, or the FVC. And this is, how much air you can blow out altogether. And if you have a low forced vital capacity, it can mean that you have that air trapping that we were talking about earlier. And then the FEV1, or the forced expiratory volume in 1 second, is how much air you can blow out in that very first second of the test. And this typically is decreased with COPD. So that volume is we would see is lower in someone that has an obstructive disease in their lungs. And then we look at the ratio of that FEV1 and that FVC. And, this ratio decreases with age. So just plain old aging will lower this measurement, but it's also decreased with COPD. And then we look at total lung capacity. So total lung capacity is how much air your lungs can hold at any given time. And so if you have air trapping, this number is going to be higher than it would in someone without COPD. And then we have residual volume. And so this again goes along with the air trapping. This is the amount of air that's left in your lungs after you feel like you've emptied your lungs completely. And so if you have air trapping, the amount of air left in your lungs is going to be much higher than without air trapping. And then the DLCO is a measurement of how the oxygen passes through the wall of the air sac into the bloodstream. And so if we have a low diffusion capacity, it could suggest that you have emphysema. And if you have a normal DLCO, or diffusion capacity, it might suggest that you have chronic bronchitis. So again, this is another test that gives us lots of information about what's going on inside your lungs. So now we're going to talk about treatment of COPD. So we have medications, oxygen therapy, airway clearance, pulmonary rehab, my favorite, and lung transplantation. So medications, I could do a whole lecture on medications alone. So I'm just going to kind of briefly cover the different categories that are out there. We have lots of different classes and categories of medications that can help to open the airways and decrease inflammation. So, the more common medications or inhalers that we have bronchodilators, which are meant to relax those muscle bands that are squeezing around the airways and help to open the airway back up again. We have corticosteroids or inhaled steroids that are anti-inflammatory medicines. So what they're trying to do is decrease the inflammation in the airway, open that airway up, and make it easier for you to breathe. And then we have these PDE4 inhibitors. So it's a phosphodiesterase 4 inhibitor. And excuse me, this is actually a pill form of a medication that has shown to reduce flare-ups or exacerbations of lung disease. If someone has frequent infections, they're hospitalized frequently, they would be a great candidate for this type of medicine. And then we have what we call mucolytics, which help to break up mucus, thin it out, loosen it, and make it much more easy to, cough up and get out of your lungs. And then we have cough syrups. We have quite the sun rays shining through the window here. So cough syrups. And when we're looking at cough syrups, especially over-the-counter cough syrups, we want to look for expectorants and not suppressants. We don't want to suppress the cough or stop the cough from happening because we want to move that mucus. We want to get it up and out of our airways. So if we suppress the cough, we're going to hold everything inside, which is going to put us at risk for infections. Again, we can do antibiotics. And if we have alpha-1, we have to do what we call augmentation therapy. And that's actually an infusion of different medications that help to build up that lack of protein that people are suffering from with alpha-1. And then we talk about oxygen therapy. So, I deal with people every single day who need oxygen. And I will tell you, no one is ever happy about being on oxygen. It's a pain in the neck. It is not a convenient type of treatment. Excuse me. And, people say, oh, I don't want to carry that cylinder around with me. I'm not going to carry that device with me. It's too heavy. It's too this, it's too that. I trip over the tubing, et cetera, et cetera. So in pulmonary rehab, we try to do our best to help make the transition to using oxygen as easy as we can. And we recognize the fact that it's a huge change and it does take a lot of adjustment. So if you need oxygen therapy, you don't get oxygen because you're short of breath. We only prescribe oxygen if your oxygen saturations or your oxygen levels are 88% or lower. So if you do have oxygen, it can help to reduce your shortness of breath or the feeling of breathlessness. It's not going to take it away completely. It can also help to reduce fatigue because some people, if you're trying to do a particular activity like walking, let's say, and without oxygen and your oxygen levels are dropping, there's only going to be so far you can walk before you have to stop and take a breather and get your breath back. And if you have oxygen's going to maintain your oxygen level above 90 where we want it to be, hopefully. And it will actually allow you to walk further before you have to stop and catch your breath. Oxygen can also help you maintain an active lifestyle. I think a lot of people look at oxygen as, oh, I got to wear this. I'm going to be stuck in my house forever now. And there's so many different devices on the market now that, we can really work hard to get you the best fit for an oxygen device that's going to go along with your lifestyle. And then we talk about airway clearance. So airway clearance is really important in bronchiectasis, but also some people with chronic bronchitis have a lot of issues with dealing with mucus management. So airway clearance therapy may be needed because there's that ineffective function of the cilia. So like I said, the cilia gets damaged. It's not moving the mucus the way it's supposed to. And, mucus can get stuck and trapped, and we need to do something about it. And then we also have that excessive or abnormal mucus production. We can develop an ineffective cough because the strength of the airways, the strength of the cough can be decreased. You have difficulty swallowing. Sometimes aspiration can cause a problem. So aspiration is when you inhale food or fluid into your lungs, or it just leaks into your lungs from having acid reflux. And again, we definitely need airway clearance with bronchiectasis. Sometimes people with emphysema and chronic bronchitis will benefit from it also. And so there's lots of different airway clearance methods. The first one on here is called huff coughing. And so this type of cough is not a plain old cough where you just from your throat. It's actually pulling in your diaphragm muscle to force the air out of your lungs rapidly. And as that air is traveling out of your airways, the goal is to have it, drag the mucus with it. So it's easy for you to move it up and out. And so huff cough is very similar to fogging your glasses or a mirror. So you're just kind of forcing the air out. So it's kind of like a like that. And then we have chest physiotherapy. So the abbreviation for this is CPT. And, we don't hear it all that often these days, but when I was a nurse in the hospitals, you could hear this all the time. It almost sounds like horses' hooves clopping on the cement. And it's percussion and pounding on the chest and back to shake the mucus loose. So we cup our hands kind of like this, if you can see me in the photo, and we do it on our skin, and it sounds just like that. And so we would do that as providers, respiratory therapists and nurses, to shake the mucus loose and make it easier for people to cough it up and out. And then we have autogenic drainage, which is a technique that involves specific breathing and coughing sequencing, to move the mucus. And then we have PEP, or positive expiratory pressure. And this is really breathing out against resistance. And what this does is causes back pressure inside the airways to help keep those smaller airways open a little bit longer. And it allows the air to get behind the mucus and make it easier to move it again. And then we have PEP and vibration. So if any of you are familiar with flutter valves or acapellas or arabicas, these are all devices that we blow into against resistance, and it actually causes a vibration of our chest wall. And that vibration is meant to shake the mucus loose. And once we've shaken that mucus loose, then we use that huff coughing technique to move it up and out. So you're getting the picture, right? All of these techniques are to move that mucus, get it out of our lungs so that we're not at risk for infections developing. And then the last thing on the airway clearance methods is a high frequency chest wall oscillation or oscillator. And so basically what this is a vest that you put on. It's a plain old vest. You put your arms through it, you strap it across your chest and your belly, and we hook it up to two tubes that inflate the vest with air. And then we set the compressor to certain volumes and time settings, and we actually shake your upper body. But it's kind of like if you're going down a bumpy road and you kind of hum and it does the that's what this is doing to your chest wall. And it's nice because the vest itself will reach all of your lung fields, front and back, all at the same time. So very common for people with cystic fibrosis or bronchiectasis to have this type of treatment. Okay, and then we're going to talk about pulmonary rehab. So, pulmonary rehab is a program that involves all of these things: exercise, breathing, retraining exercises, helping people manage anxiety and stress and depression, because it is stressful to have lung disease. It is anxiety provoking when you can't breathe. We talk about, proper diet. We have a dietitian who works with us to help people choose the right foods. And it's not just about weight loss. Choosing foods that don't affect your breathing is really important. So there's lots of foods that cause a lot of bloating, a lot of gas. And if you're filled with that gas, it makes it much more difficult for your diaphragm muscle to move and for you to breathe. And we teach you about all kinds of different topics. We teach about normal function of the lungs. We teach about different lung diseases. We teach breathing techniques, like I said. We talk about relaxation techniques. We talk about the importance of sleep. And the other part of nutritional counseling is drinking plenty of water. If you are dried out and dehydrated, that causes your mucus to be much more thick and sticky. And so if we drink more water, we're going to thin that mucus, we're going to make it less sticky, and it's going to be much easier to clear it out of our lungs. And then with the exercise training, we're improving your strength, we're improving your endurance. We're hoping to maintain your quality of life. That's what it's really all about, is being able to, live your life the way you want to, and be as healthy as possible with lung disease. And so it just so happens that this week is Pulmonary Rehab Week. So Pulmonary Rehab Week this year is March 10th through the 16th. And so we're doing some fun things in pulmonary rehab in the gym. So you can see the poster, and this is a national celebration. It's not just here at Baystate. So this is happening around the nation. So we have our nice board decorated here, and then one of our exercise physiologists got very creative, and she made a pulmonary Jeopardy board. So we've been playing Jeopardy all week. Underneath each of the categories, we have all these choices. There's a question about lung disease in one way or another. And, we throw it out to the group and see what they come up with for answers. And it's a great review about all the things that you learn in pulmonary rehab. And then on the other side of the slide here, we have our balloons, and we have our little goodie bags. You can see them on the shelf in the back there on the countertop. So we gave out goodies to everybody in the group. So in the goodie bag, we have hand sanitizer, a little package of tissues. We have bubbles so that you can practice your pursed lip breathing, blowing bubbles. We have a little coloring page that has lungs all over it. Coloring is a nice relaxation technique. And then one of our triage nurses made these what do you call them? Pot holders, but they go in the microwave. So you can put a bowl or a mug in the pot holder and put the whole thing in the microwave. And when you take it out of the microwave, you have the pot holder to hold on to, so you're not burning your hands on the bowl or the mug. So a really cute idea. So that's my plug for Pulmonary Rehab Week. So we try to have as much fun as we can in the gym, because we know that exercising is stressful. Some people hate to exercise, and it takes a lot of motivation and fun to keep people moving and grooving. Okay, so the other treatment for lung disease is lung transplantation. So you can have a lung transplant done, and you can have one or both lungs replaced. And I will tell you, there's very strict criteria for being a candidate for lung transplantation. And there is extensive testing that has to be done for you to be a candidate. And once this testing is done, you're placed on a waiting list. And you also receive a priority score that's called the Lung Allocation Score, or LAS. And so it makes sense that as a person becomes sicker, that LAS gets higher. And as that score becomes higher, that person will move up on the waiting list for lungs. And, as you know, lungs have to become available for someone to get a transplant. And unfortunately, we have not figured out how to grow lungs in a lab yet. I'm sure that will come eventually, but probably not in my nursing career. However, so the only way the lungs become available is if someone else passes away, unfortunately. And then those lungs are tested for viability for transplantation. And then the people on the waiting list are called when those lungs become available. So, there's lots of risks involved, just as there are lots of benefits from lung transplantation. The risks are infections, rejection of the lungs themselves. There's lots of medications that you're on after a lung transplant, because we have to give you medicine so that the body doesn't reject the new lung that's been transplanted. And so the survival rate for or after lung transplantation, 85% survival rate after 1 year, 67% after 3, and 54% after 5. And these numbers are from 2021. So there's probably new numbers coming out sooner than later. All right. So these are the resources that I've got, that I received all this information from. The COPD Foundation is a fabulous resource for all of you. And they actually have this 360 Social, which is an online community that's available if you're into using the computer, and also the American Lung Association, and then the Mayo Clinic. So let's see. My last slide is a nice picture of some healthy lungs. So I guess we can take some questions, Sue.
Well done, Michelle.
I
love that. And congratulations on Pulmonary Rehab Week.
Well,
I want to play that Jeopardy game. That looked really good. What's that?
I said she did a great job on it.
Yeah, in the bag. Wow, you guys know how to celebrate. So we do have a number of questions in the Q&A box that that if you have time to answer. It looks like we have some time. And I invite anybody in the audience who has questions to type them in the Q&A box for Michelle. So the first one is, what triggers too much mucus production in chronic bronchitis?
Okay, so what's happening is that the lungs themselves are irritated by something in their environment. So, if we inhale something past our nose and mouth that's not supposed to be in the lungs, then the brain says, oh, we got to do more cleaning down there. And it tells, the body to produce more mucus. So the things that trigger that again are the same kinds of things that we talked about as far as the exposures go. So cigarette smoke, fireplace smoke. Sometimes people are really bothered by perfumes or colognes or things like that. The big offenders in the house, people insist on using bleach and ammonia, which are toxic to anybody's lungs, not just people with lung disease. So those are the types of things that can trigger that extra mucus to be made.
Oh, good thoughts on that. I didn't even realize that about bleach, but that makes sense.
Yeah.
Yeah. Okay. Thank you for that. And the next question, this person is just looking for some clarification. Bronchitis is a type of COPD or it occurs in people with COPD?
So chronic bronchitis is a type of COPD. So emphysema, chronic bronchitis, and bronchiectasis are all types of COPD.
Excellent. And then the next question, are PFTs invasive or painful?
Not really invasive. I wouldn't say painful either, but it's a workout because they make you do so many different breathing maneuvers. So typically what they'll do, if you've ever, for those of you who've had a PFT, people will say, oh, they yell at you when you go down there. So what they're doing, they're trying to coach you to do the best that you can with the breathing technique. So one of the maneuvers that they do, they pinch your nose and they put a tube in your mouth and they tell you to take a big deep breath in, and then you have to blow it out as long as they tell you. So that they're yelling at you, they're going blow, 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 and you're blowing until you feel like your head is going to pop off your body. And then they say, okay, take a deep breath in. And so it's a workout. So I wouldn't say it's painful. I mean, the only invasive thing is when they would do the ABG, the blood draw. But yeah, it's tiring. And sometimes people are not able to do all of the maneuvers that they're asking you to do.
Sure, so. It does sound difficult.
And right? If you ever go by the pulmonary function lab, you can hear the respiratory therapists yelling at their patients, but they're being kind. They're not being mean.
Wow. Well, clearly you have empathy for your patients, so that's really great. Maybe have you obviously tried it or put through the paces often enough?
Oh yes,
with patients. The vest, wearing the vest and having that vibrating is really interesting too. I didn't know anything like that, but that must be satisfying when it's done. But imagine.
Yeah, that's another thing. A lot of people, I would say some people can't tolerate it because when you fill that vest with air, it's kind of squeezing your chest wall and then it's shaking you. And it's like, you can breathe, but you have to really focus on your breath as you're being shaken like that. So yeah, takes some adjustment, no question.
Oh my goodness. Well, God bless you. The next question, once you start rehab, is it a lifelong commitment or do you graduate?
So our program itself is 8 weeks long. So once you complete that 8 weeks, you do technically graduate, but exercise is a lifelong commitment. So you don't quit exercising after you graduate, from the 8-week program. We encourage you to continue to exercise, through your lifetime, because that's going to keep not just your lungs healthy, but your overall well-being healthy. So.
Yeah, thank you. Yeah, I guess with everybody, gotta, everything, being healthy is a lifelong commitment, right?
Exactly. And, if you read about any medical condition, one of the treatments is exercise. It doesn't matter what you look up, it's going to tell you exercise is one of the treatments that you should be doing. So,
right. Good note. Thank you. This one is about a specific scenario. This person had 2 scoliosis surgeries and was having breathing issues, and they're wondering if there's any help for that. They've learned to live with it, but they're wondering if there's any particular help for these individuals.
So, scoliosis is a curvature of the spine. So if the curvature is significant enough, it can cause restriction of how well the lungs can move in and out. So I think probably the help that is available, I'm sure exercise would be important. And breathing techniques would certainly be helpful also. Help strengthen the diaphragm and help control the shortness of breath symptoms.
Excellent. Thank you. This next question is getting back to our earlier topic about bleach and inhaling things. Mm-hmm. And if you over inhaled a bleach or a cleaner, can your lungs repair, or is that damage permanent?
I think it's hard to say. I think it's repetitive exposure that would cause lasting damage. And that's kind of, I think, the way it goes with most exposures, like cigarette smoke. If someone only smoked 1 cigarette in their whole life, their chances of emphysema are pretty slim. But, if you smoke 2 packs a day for 20 years, then that exposure is going to be much worse as far as the damage to your lungs go. But, and some people insist on using bleach and ammonia. So if you're one of those people, I highly recommend that you use a mask when you're cleaning and make sure that the room that you're cleaning is well ventilated. So if it's the bathroom, make sure a window's open, that the door is open. If you have a fan going, just to keep that air moving, because it can also make you lightheaded and pass out if you're in a small enclosed area. So just want to be cautious.
Thank you. That's an excellent tip. And it's great for us to be aware of that, because honestly, I mean, if anybody's like me, it never occurred to me. You're just like, I need to clean this bathroom, right? Yeah. Not like, oh, this is going to do some damage.
And, the plain old soap and water will get everything just as clean as bleach will. It just won't smell like you cleaned.
Excellent point.
It won't smell like a swimming pool in your house.
Good one. Well, it looks like we've come to the end of our questions. If anybody wants to jump in one last one, we're coming up to the end of our time anyway. But I want to thank you, Michele, for your time and expertise. It's really been enlightening. And thank you to our audience for joining us tonight. We really appreciate it. So I don't see anything else coming in. So thank you all and have a great night.
All right. Thank you. Take care.